We're going to be talking about access to care and health insurance coverage. Our moderator for tonight is Dr. Ben Raimer, who's a senior vice president and professor at the University of Texas Medical Branch. For those of you who don't know, that's in Galveston. He's also a member of our executive advisory committee to the Health Policy Institute. So we're very pleased to have him moderating tonight. Dr. Raimer.
Thank you very, very much. I'm glad all of you are here in Galveston. It's a very foggy evening. We can barely see the water. Barely. That's East Texas term, meaning not highly visible. We are glad to be with you today. We're glad to be a part of the Texas Medical Center. We're certainly the southernmost branch of your medical center, and we're glad to be a part of the Texas Medical Center's Health Policy Institute. It's my privilege today to also introduce to you several of the people who are with me today. They represent our faculty. Dr. Cara Pennel. Dr. Pennel is an assistant professor in the Department of Preventive Medicine and Community Health. That department has been around for a long, long time on the island. It's our version of our public health department. He has many facets that include everything from aerospace medicine and occupational medicine to the awarding of degrees in public health. So a little bit of everything there with special tailored programs. A lot of our medical students do combined MD, PhD programs or MD, M.P.H programs. I'd also like to introduce to you Dr. John Prochaska. Dr. Prochaska is a assistant professor also in the division of PM&CH, and he has interest particularly in social determinants of health, in healthcare assessment in communities, and in planning. Dr. Pennel's expertise is focused in a variety of areas in the public health domain, but particularly in the area of public health in general. And also with us tonight and filling in for her major professor, Dr. Call, is Jacqueline Avila. Jacqueline is completing a doctorate degree. If she breaks into Portuguese at a moment, it's because her native country is Brazil, but her home country is now the United States. She brings an area of expertise to us in delivery of health care to young adults. So she may also break into millennial speak. I'm sure you can follow that. I want to also just take a moment to talk about access to health care. We all come to a point like this with our preconceived notions about what health care access really means. For some, it's as easy as can I get an appointment or not. For some, is I can't find my way. Several years ago, we had a HRSA grant, a Health Resources Services Administration grant for $1.9 million in Galveston to pilot a study related to what do people really want in healthcare. Well, I've been in healthcare for a long time. I'm a pediatrician. I had 20 years of practice in general pediatrics before joining the university in both pediatrics and administration. I spent a lot of time delivering health care myself, so I kind of thought I knew what people wanted. But we went out to our community to do something called a needs assessment, something John is quite proficient in, which is what you do before you go spend $1.9 million. If you're doing it the right way, you find out where that money should be spent. And we convened groups of citizens in various areas in our community. The first message to me is we did that at public schools where we would get people who had children involved, particularly in that decision making, and in neighborhoods. And the first thing that came to mind for us at Galveston was in one particular school, we had 9 groups, focus groups. 6 of those focus groups were Spanish speaking only. So there was a message to carry away regarding communication. We also surveyed all of the community, and what do you think was number one on their list regarding access to health care? Insurance? Transportation. Surprised me, as it would most affluent white people who have 3 teenagers with too many cars in the driveway. You know, I had not thought that transportation was a problem. We began our work in our community, and what did we discover? We discovered there was no bus stop at the hospital or any of the clinics. Now, some people could look back and say maybe that was on purpose decades before, who knows? But there was not easy access. The end result, our project led us to making transportation a priority, building a transportation center at the hospital, and providing on every appointment for every patient a detachable transportation pass to and from the hospital for anyone going through special transportation or going by bus. In a partnership with that, it gets better. Guess what happened in a partnership with our community? With your UTMB, I'm sorry TMC, but UTMB name badge, any employee could ride the bus free, and so could all of our students. So transportation for all, not just one person. So good things can come in places you least expect it. That's my message as we lead off. And we're going to draw straws to see who goes first. John will start with his topic, okay? Thank you, John.
Thank you so much, Dr. Raimer. Good evening. Thank you all for being here. It's really a pleasure and an honor for us to have the opportunity to talk about this topic this evening. I'm going to start off with some of the more boring side of things, I think, the numbers, the demographics of what it looks like to be uninsured in Texas and what access to care can look like. Who's uninsured in Texas? It's an interesting question, and when you start really drilling down to it, it sheds light on a lot of the issues we see when we're looking at readmissions, when we're looking at patients who are presenting with more severe conditions at the hospital or in many different hospitals. So our latest estimates come from the Census Bureau from 2016. What proportion of Texans ages 65 and older do you think have health coverage?
20%.
Over 65. I'm hearing 20%. I'm hearing Medicare. Yeah. Just about every one of them. There's only 1.9% that are uninsured. Once you reach the age of 65, you're now eligible for Medicare, and you have access to health insurance that way. What about children under the age of 18? 25%. Close, a little lower. 10 to 15%, depending on what estimates you look at. So it's much better. The big gap happens once you turn 18 or 19. Particularly now with Affordable Care Act extending parental coverage for children up into the 20s, it's really starting to show a drop-off in terms of health insurance coverage once you hit 20, 25, 35, 45 years old. In that age range, you're looking at about a third of people are currently uninsured in Texas by census estimates. This does not include undocumented. These are documented residents here. Yeah, that's a different denominator to talk about. When you start looking at those that are uninsured a little bit more in depth, you see differences by race and ethnicity. So white non-Hispanics, about 11% are uninsured across all age groups. When you look at Black or African American residents in Texas, that's 17%, so approaching 1 in 5. The big difference happens when you look at the Hispanic or Latino population. About a third of that population is uninsured in Texas. It's a huge gap. There's also a gradient when you look at education. So there's a very large incentive to go to college and to complete your bachelor's degree or go on. For those that are that have a bachelor's degree or higher, only 7.2% of those Texans are uninsured, versus those that have less than a high school education, they didn't finish high school, almost half, 42% are uninsured. Why do you think that is? Employability. So the types of jobs that you would get with a bachelor's degree or higher comes with extra benefits, right? Yeah, that's a big driver. Not surprisingly, those that are unemployed are about half of them are uninsured, as opposed to 24% that are in the labor force. Also, how much you work. Those that are in full-time positions, for example, only about 20% of them are uninsured versus those that work less than full-time, about 35% are uninsured there, which is actually higher than those that aren't working at all. We also see a similar gradient when you look at income. Those with higher incomes are more likely to be insured through different mechanisms, either through their employer or they have a better probability of being able to self-insure. What's interesting in Texas is we also, when you look at income in terms of poverty level, you see the same gradient we've seen before the Affordable Care Act, and that is those with the lowest incomes, those that are below the 138% of poverty level, have the highest levels of uninsurance. Why might that be the case? Medicaid Gap. Yes, so there's this thing called the Medicaid Gap. In Texas, you can get Medicaid if you are a child in your household income is less than 206% of the federal poverty level. That's roughly $48,000 a year or less for a family of four. If you make less than that and you're a child, you're eligible for Medicaid. If you're a parent of a small child and you make 19% of the federal poverty level or less, you can get Medicaid. And that is $4,500 a year or less in total income. If you don't have any children, you are not eligible at all. And there are other safety net programs that can come into play, but that's only for the very, very lowest of incomes.
How does those statistics compare to, say, California?
That's a very good question. I don't know exactly off the top of my head, but since they did expand Medicaid through the Affordable Care Act, that covers that gap. So the idea behind, I wish I had this blown up as a slide. The orange area is the area that's the group that's uninsured. And we can provide this as a PDF if needed. What the orange area is the area that is expanded if you expanded Medicaid with adopting the Affordable Care Act. Texas opted not to do that and is doing a couple of other programs, which Dr. Pennel will talk about here momentarily. So with that, that's health insurance. Does having health insurance guarantee access to care? Now, we talked about a couple of issues earlier. Dr. Raimer brought up one of the most important, which is transportation. There's another issue, and that is being able to find a doctor available. We have a physician shortage in the state, and it's looking like it's going to be with us for a while. I went this afternoon to the Texas demographer's office. I don't know if you knew this, but the state has its own demographer. They're responsible for doing all kinds of wonderful things like projecting. It's a scientific guess. I would not say, demographers do not guess. It's a very conservative estimate, but they look at population projections for every county for the next 30 to 40 years. For Texas, currently we have about 27 million people in the state. With primary care physicians, our current ratio is somewhere around 1,000 to 1, 1,050 to 1. What that means is for every one doctor, there's 1,000 people that they can cover. In Texas, we're projected to go from 26 million people to about 40 million people by 2050. That's an increase of about 12 million. To keep that same physician to primary care physician ratio to population, we would need to graduate and put through residency almost 13,000 primary care physicians. What that means is we'd need about 40 years or more worth of every UTMB medical school graduate to go into primary care in the state of Texas. And we need that in the next 35 years. That's looking at just one medical school, but it's showing you the scope. I looked at a couple of counties just to get a better idea of what that looked like on a more local level. I picked Brazoria County. It's projected to be one of the top 3 fastest growing counties in this state over the next few years. For the same time period, there's currently 342,000 people in Brazoria County, and it's projected to go up to almost 600,000. What that translates to maintain the current ratio of primary care providers to patients, they will need an extra 158 primary care physicians in the next 35 years. I might also mention that their ratio is not as good as the state. So that's just to maintain the status quo. Right now they have 1 physician for every 1,570 residents, as opposed to the state average of 1 per every 1,000. So.
What are we doing to prepare for that problem?
That is such a good question. I would actually defer to my colleague, Dr. Raimer, on that one.
He's doing that because for 13 years I served on the statewide health coordinating council that looks at projecting the needs of our healthcare workforce for the state. And what that means is that we need to completely train more physicians, not just graduating from medical school and send them out to a residency program. Because if we do that and they go outside the state of Texas, 50% never return. How much does it cost to train a medical student to graduate 4 years of medical school? Anyone want to guess? Somebody said $1 million. Most medical schools would tell you it's around $800,000. How much does your state provide in tuition? I'm not going to get into testy ground here, am I, Dr. Garson? But the answer to that is not enough. And with the flurry that you're seeing in opening new medical schools, we did so much of that 2 years ago that we exceeded the residency slots or graduate medical education slots available in Texas. And so Texas students who graduated could not get a residency in the state and had to go outside of it. So as a taxpayer, that is not a good investment for you. What is a good return on investment is to grow your graduate medical education slots as much as you can. And your legislature heard that, and for a remarkable time, they listened. They invested $60 million in the 84th legislative session, and in the 85th, they upped another $20 million or so into graduate medical education. That is a smart investment. How much do they need? 2 to 3 times that amount in order to grow the number of slots. We ought to be importing doctors to Texas, not sending them out of the state. And you just think it's a normal experience. No shame on the young men and women who go to another community to live. If they move to North Carolina and they're single, there's a good chance over 3 to 5 years of a residency program, they're going to meet someone, get married, and stay where their spouse's family lives. That's just life, and there is no amount of money that changes that. So your question is a really relevant one. You should be talking to your state representative and senator about increasing residency slots right here in the Texas Medical Center and the other hospitals in Houston, because the other thing is where a medical student does his residency, he's most likely to practice, he or she, within 100 to 150 miles of that spot. So you want to have more doctors for Houston, have more residency slots for Houston. Building another medical school, I get in trouble for saying this, doesn't solve the problem, particularly if that person has to go out of state and do a residency somewhere else. And those are just the hard, cold facts. By the way, of that $800,000 it costs to train a medical student, about $200,000 of it comes through tuition fees and state support. The other $600,000 comes from those medical schools because the doctors who work in those medical schools work in something called a practice plan in those schools, and that money and the hospital money go to supplement medical education. So that's something you never see on the bill. Yes, ma'am.
Okay, so I have a question for you. So I'm a recent graduate from University of Houston, and I have a lot of friends of mine who, were pre-med, going off to, medical school and all that. And I have a lot of friends that, okay, so basically my question is there any way, or how can we possibly get higher or provide higher salaries for primary care physicians? Because my friends specifically said that, they wanted to, I don't know if I want to do emergency medicine or cardiology. They wanted to specialize because there's more money. They would earn more money with the specialization. But what we need are more primary care physicians. So how can we kind of balance that out?
And you're seeing some incentives that are built into contracts now, both through the federal government and through insurance companies to draw people into primary care. For instance, there are incentives added if you're practicing in a rural or health profession shortage area. There are loan repayment programs if you go into areas where there is a shortage of physicians and they're medically underserved areas. Those can assist you in paying off loans. The average student across the United States completing medical school and their undergraduate school will have about $200,000+ in debt. So that's a very highly attractive thing for them to get into, is debt forgiveness. Of course, after the debt is forgiven, they often make a beeline to a large metropolitan area where they can increase their earnings. But that is something that's attractive. The other thing is medical students are being asked now more and more to serve in underserved areas while they're a student, so that they can get an idea of what it's like to live in rural communities. And there are students who are recruited to medical school who like that lifestyle, and they'll opt for that. Our need is simply to have the funds to offer more students a small award, a grant award or something to go and spend time there. Your Texas government has also looked at that through the state coordinating board, and there are some awards for students now to apply and get a scholarship to serve in an underserved area with a primary care physician. So there are some programs like that. And the National Health Service Corps is also another option. I'm sorry I'm eating up you guys' time.
No, this is great. I love discussion.
So,
Okay, go right ahead.
that was the end of my opening remarks, actually, so perfect timing.
I'm Cara, Pennel, and I am, as Dr. Raimer said, assistant professor in preventive medicine community health, and I'm also the director of the public health program at UTMB. Before I say a little bit more about why I'm here, because I'm not a health policy person, I wanted to build on something that Dr. Prochaska was saying about the Medicaid gap. So do you all know how many people fall into the Medicaid gap? Nationally. Well, if you think about the population that's insured, so that's about what overall, about nationally, we're looking at about 80% to 85% that are insured. So it's 1 million people fall into the Medicaid gap. And I've kind of wanted to talk a little bit about who those people are. So more than 2/3 of those people that fall into the Medicaid gap are people of color. Almost 75% are adults without dependent children. 55% are women, and more than 2/3 are working families. So these are individuals. We hear a lot of times about, people that aren't working and they shouldn't have assistance because they aren't working, and that's not the case in this situation. Over 2/3 are working families that don't get insurance through their employer, but also are not eligible for Medicaid and don't make enough for the marketplace either. So I'm broadly a public health and community health person. I do a lot of work in community assessment, planning, and evaluation, and it's because of that work that I have worked on a couple of projects that are related to access and insurance. So one of those areas is nonprofit hospitals. I'm guessing, is everyone aware that nonprofit hospitals are nonprofit organizations and are therefore tax exempt? But there are certain things that nonprofit hospitals have to do because of this tax exemption. They have to report what percentage of their operating expenses go to community benefit. Community benefit is very broad, so this is reported to the IRS. Community benefit is fairly broad, so it includes things like charity care, Medicaid shortfalls, so making up what you've lost. You aren't reimbursed from Medicaid, and it includes other things like community health initiatives. It involves research, and it involves things like continuing education for clinicians at your hospital. So can anyone guess what percentage of hospital operating expenses go to direct patient care versus things outside the hospital that don't involve direct patient care? Any guesses? So those things like research, continuing education for clinicians, community health, improvement, those are things that we don't consider direct patient care. But it's charity care, Medicaid shortfalls, those are the things that we consider direct patient. 5%. So 85% goes to direct patient care. 85%, this came from an article from about 2009, I think, New England Journal of Medicine. 85% of nonprofit hospital operating expenses are going to direct patient care. And this is of interest to me because as a community and public health person, we know that there are things going on outside the hospital and clinic walls that are attributable to poor health outcomes. And it's things like community health building, community health improvement, and things like that will help improve overall health outcomes, right, for any public health people in the room. So that's one of the reasons why this is kind of my area, is nonprofit hospitals, and specifically, and what they can do to contribute to uninsured and underinsured through the community benefits they provide to a community because they don't pay taxes. The other thing related, yes?
So the 56 to 58 organizations at the Texas Medical Center, can you help people understand how many of those organizations are nonprofit organizations?
That's a really great question.
It's the majority, correct?
Yes, it is. And although Texas overall has a smaller percentage than the rest of the United States when it comes to nonprofit hospitals. So nationally, you see that about 60% of all hospitals are nonprofit. In Texas, it's 30% that are nonprofit. And these may be a little bit off. This is my data's maybe 3-4 years old, so that may have changed a little bit. But nationally, the majority of hospitals, more than half, are nonprofit, and that's not the case here in Texas. And part of that is because there are state hospitals that don't necessarily fall under that nonprofit status. Is there another question?
I was just going to ask you, why not?
Yeah.
Why are
Yeah, I think that's part of it. We see, especially in the Northeast, there's a higher concentration of nonprofit hospitals than there are in other parts of the country. But I think part of it here in Texas is because we have state hospitals that kind of offset that nonprofit.
Cara, does the corollary to that mean that those hospitals are not investing in screening patients, prevention programs, and health literacy? Is that a fair conclusion?
So I would say that programs like that, this is a good segue into the next thing I was going to talk about related to nonprofit hospitals. So part of the Affordable Care Act is that, and this is the small narrow piece of the Affordable Care Act that I know, the rest of the thousands of pages I don't. So it's nonprofit hospitals have to conduct a community health needs assessment, identify health priorities, and implement strategies to address those priorities every 3 years. So how many of you were aware of this? Okay, so a few, maybe 5 or 6 people who are aware of this. So the idea behind this, there's been some criticism historically that nonprofit hospitals aren't doing enough to justify their tax-exempt status. And so as part of the Affordable Care Act, they said, we need you to do more. We want you to assess the needs of your community every 3 years, identify priorities. We want you to engage your communities in this process, and then identify and implement strategies to address those priorities. And I think this is where some of those programs come into place, often for nonprofit hospitals. So things like screening, health literacy, we see a lot of nonprofit hospitals that are doing things like that for uninsured and low-income populations that might not normally have access to those programs. So that's my one area is related to nonprofit hospitals. My other area is the 1115 Medicaid Waiver. Is anyone, I know there are some people who are very familiar with that here. Is anyone familiar with that? Okay.
I have a quick
Oh,
question
yes.
Before you go on about the nonprofit hospitals. So when you say that they have to identify priorities and implement strategies to address the needs within their community, do you mean within their geographical community, like where they're located, or where their patients are located? You know, like let's say, for example, a majority of their patients, you know, come from like Sugar Land or something. Like, is it kind of like that, or like?
That's a great question, and that was one of the comments that came back when this was out for public comment. Hospitals said, well, how do we define our community? And they've really left it up to hospitals to decide. They have some restrictions, so you can't say we're not going to include certain populations in this. We're not going to include homeless populations in this. Now, if a hospital predominantly serves homeless populations, they can focus on special populations. There's some nonprofit hospitals that do serve special populations, right? Some here in the Texas Medical Center. And so they can focus on those special populations, but otherwise they really want them to focus beyond their patient population. A lot of hospitals that I've seen are using what they call their primary and secondary service areas. And there's an equation that goes along with that. I'm not a healthcare person either, but there's an equation where they can figure out what percentage of their patients come from certain areas based on zip codes. And so that's what we're seeing a lot of nonprofit hospitals doing, is looking at their patient population, but using geographic boundaries by zip code to identify their population.
Thank you so much.
You're welcome. Any other questions about nonprofit hospitals before I move on to? Yes.
I think one of the really interesting things about it, because I think community benefits could be a 2-hour talk in and of itself. And I think one of the things I just wanted to ask about is how hospitals can actually get around doing some of those things, because it all depends on what counts, because it's all an IRS form.
It is.
And so depending on what you do, I think there are certain things that you do within the hospital that count as that benefit, and so you get to that percentage that you're supposed to hit. So I think historically hospitals have been able to get away with it, because at the end of the year, they just look at, money losers in the hospital, whether they be clinics, services. They count all those things, and then they hit the threshold, and then they're done. And so I think my question is, how much do you think this added pressure from the community needs assessment actually adds, because you can still do all those things just with a community needs assessment
Right, and I
attached.
definitely think there is some overlap that goes on between community benefits reporting to the IRS and the community health needs assessment. And by the way, it is the IRS that oversees the community health needs assessment, prioritization of health issues, and implementing these strategies, which I think is kind of interesting. Although they did consult with the CDC, apparently. But I think there's a lot of overlap between that. And you bring up a great question related to percentage of operating expenses. So we talked about the percentage of the community benefits that goes to direct patient care, but what about the percentage of overall operating expenses that goes to the entire category of community benefit? What do you think that would be for hospitals, nonprofit hospitals? So it's about 7%. So this article by Gary Young from 2009, he's at Northeastern, they found that it's about 7%. However, there are some that are doing very little, 2 to 3%, and academic medical centers tend to be doing the best job. So they're pulling a little bit more of the weight than traditional nonprofit hospitals. They're about 20%, contributing 20% of their operating expenses to community benefit. So I don't know if that answers your question exactly, though. But I do think there's overlap between what they do for community benefits, community health needs assessment, and there's been some criticism, too, because some of this just seems like a checkbox. I will say, however, I found out recently that the IRS did pull nonprofit status from a nonprofit hospital. So they are no longer nonprofit. They are no longer tax exempt. Of course, they have the letter online, but it's redacted, so you can't tell which hospital it is or where it is. But I think that's interesting because for a long time, people have been saying there's not teeth in this. But if they're yanking a hospital's nonprofit status, and they now have to pay taxes, there's more teeth in that, I think. So that's the nonprofit hospitals are one area that I think can provide benefits to those who are uninsured and improve access to care. And then my other hat that I wore for quite a while was working as an evaluator for the statewide Medicaid waiver, Medicaid 1115 waiver. So how many of you are familiar with that? I already asked that, didn't I? Okay, so several people are familiar with that. And as part of, does anyone know what's the purpose? What was the purpose here in Texas of the Medicaid waiver? Transform the healthcare system. Was it to expand coverage? Anything else? I'm going to write these down. Innovation. I'm sorry. Offer new services. Improve delivery. Improve access to care. What was this one?
Prepare for Medicaid expansion.
Oh, there we go. There we go. So, and this is what I'm sure there are different opinions and what the real purpose was, but this was coming at a time. So the Medicaid waiver in Texas was accepted by the federal government. And for those of you, so this is a shared program by the federal government and the state, and what they call IGT, which is intergovernmental transfers. And so they all contribute money to this. And the idea at the time, this is coming around the time of the ACA, Medicaid expansion, the healthcare marketplace, and from what I understand, a lot of people were scared. What's going to happen when all of these people that did not have insurance before need providers? What's going to happen? So part of this was to prepare hospitals and providers for that influx of patients they had not seen previously. Now, what happened was 6 months later, Supreme Court ruling came that states did not have to expand Medicaid. It was up to the state whether they wanted to do that or not. So that was kind of the primary impetus. But that wasn't what ultimately happened because of Texas did not expand Medicaid. I wanted to go back to some of the transform the healthcare system, innovation. So a big part of these projects for the 1115 Medicaid waiver were to start, so that the federal government allows states that have the waiver to do things they wouldn't normally do. And so part of this is transforming the system, improving access, cost savings, improving quality of care, things like that. Now, I did hear a couple of people say things like expand coverage, improve coverage, and the waiver does not do that. So it does not expand coverage, it does not improve coverage. It doesn't give insurance to people who are already uninsured. So let's see. Trying to see what else I wanted to say about that. So does anyone have questions about and that some of you in the audience have more expertise about this than I do, I am quite certain. And I think it'll be interesting to see how things go moving forward. So there was a 5-year renewal for the 1115 Medicaid waiver after a 15-month extension. I'm fairly certain, I don't think there would be a lot of disagreement in that if the administration had stayed the same, I don't know that Texas would have gotten a renewal because a lot of this was predicated on Medicaid expansion. And I think moving forward, it'll be interesting to see how things play out. At the national level, there's some interesting things going on. Actually, I was talking with a student about this not too long ago about how things are shifting. So in terms of the project criteria, how the federal government has kind of changed what the criteria are. And he said, well, isn't this law? It can't be changed. It is what it is. I said, interpretation and implementation, there's some room for flexibility there. So there's now a focus nationally on the Medicaid waivers of this kind of return to work. So they're calling it work and community engagement. And I see nods, so there must be some awareness of what this is. But the focus has shifted. I think it's interesting that the demonstration criteria for the Medicaid waiver at the national level now don't have the word Medicaid in them. And they do talk about improving access to commercial insurance. And so it sounds to me like a big goal is to move people into jobs. And eligibility criteria for Medicaid will now be to have a job or to be doing things to get a job or to be otherwise somehow engaged in your community to be eligible for Medicaid. So, any questions? I can pass it on to Jackie.
Thank you. Well, again, my name is Jacqueline, and I'm a third-year PhD student, and I'm covering for my mentor, Dr. Sapnakal. And we've been working together for the past 3 years with a population of adolescents and young adults. And I'm really happy to be able to talk about this population with you because before coming to work for her, I had never worked with this population, but she's so passionate and her work is so important that it really drove me to love working with this population. So we work especially with the young adult population with cancer, and we look at their health outcomes, for example, how they use preventive services after surviving adolescent or young adult cancer, how they deal with medication costs and how are their behaviors, different health outcomes, and more recently we're also looking at survival of these individuals. But today I just wanted to talk to you about healthcare access and healthcare utilization in the specific age group and why they are vulnerable. If you remember what Dr. Prochaska just said about the numbers and the figures, you see that children are protected of uninsured in adolescents too, and older adults are too, and you see this gap, especially between those that are 18 to 24 years of age. And of course, this was also before the ACA, which is the second part what I'm going to talk about. What happened to the insurance rates and also the access to healthcare utilization in this young adult population after the ACA. So young adults in the literature, they're between 18 to 24 years of age, but depending on the literature, you can find up to 39 years of age being considered young adult. So basically, I am a young adult. So if I could just use one word to describe this population, is transition, right? So what are just some basic transitions that young adults are going through in life and in healthcare? Marriage. College or not. Jobs. Right? First job. And what about in healthcare? Is there any transition when you're after 18 and before 18? Yes, and also think about navigating through healthcare. Before you would go to a childhood center, probably with your parents or guardians, and then now after 18, you're in an adulthood center, and you're pretty much left to navigate the healthcare system by yourself. How do you get healthcare, and does your job provide healthcare? As many of you said, work is a moment of transition for them. So the first entry-level jobs or part-time jobs sometimes don't offer employee-based healthcare. So that you can get the idea of why this is a vulnerable population. But what we see is that they're rarely treated as a specific group in policy programs and in research. They're either grouped with adolescents, but most often with adults. As we just saw the numbers, from 18 to 64, those are the figures that we get. But if you look more specifically at the young adult population, you'll see that their health characteristics and their health care access and utilization is also very different. And do you think young adults need health care? I mean, aren't they healthy? And older adults are the ones that need health care, right? So what do you think about that?
Some get sick.
So chronic diseases, what do you think are the main issues of health care for young adults? Is it chronic diseases? Drinking, obesity,
Sexually transmitted
STDs, yes, very good. So sometimes we have this idea, this myth that young adults don't need healthcare. This is something for older adults. But actually, if we look at three main characteristics of young adults, we'll see why healthcare, especially preventive healthcare, is very important for this population. First, young adults have poor socioeconomic status. Near 17% of young adults are in poverty, and within the young adult population, you'll see that that's a common theme. There are many gender and race and ethnicity disparities within this group. So non-Hispanic blacks and Hispanics are more likely to be in poverty, as are females. And second, mortality in young adults is twice the one in adolescents. And what do you think are the leading causes of death in young adults? Accidents, motor vehicle accidents, unintentional injury, and the second one? Overdose? No. It's homicide, so violence. And again, here, there is, within the young adult population, disparities by gender, as males are at greater risk for mortality than females, as by race and ethnicity, as American Indians and Alaskan Natives and non-Hispanic blacks are more likely to have higher mortality rates. And then the third one is the risky behaviors that some of you already mentioned, that young adults either start or peak during this age group. So cigarette smoking, for example. Any idea of what the proportion is among young adults? Higher. 40% of young adults reported smoking, and that's compared to 12% among adolescents. So there is a difference in this group, and among adults, if you look at the 26 to 40 years old age group, it's 25%. So they're not adolescent behavior or adult behavior, they are their own age group, and that's what we're trying to do with our research and with this presentation here, make awareness of this important age group. Substance use, binge drinking, illicit drug use, as many of you said, STDs, all peak during young adulthood. But one statistic that's really important for young adults is mental health disorders, especially suicide, because the suicide rate in young adults is triple of the adolescents. So 11% 11.5% of young adults committed suicide versus 3.5% of adolescents. That's the suicide rate among young adults. And remember, within all of these outcomes, mortality, socioeconomic status, risky behaviors, there are gender and race disparities within the young adult population. So you see all these conditions and all these risky behaviors, but all of them have in common is that they're preventable. And preventive health is really key for young adult health and consequently adult and later life health, because the onset of chronic conditions are going to happen earlier or later depending on their health behaviors. And so prevention is key. So from this part of the talk, just health of young adults, it's important to remember prevention and also mental health disorders. We'll go back to that whenever we understand their care. So when you look at that health conditions, you want to understand if they're able to access care. But as we already saw, young adults have the lowest insurance rate of any group. So near 30% are uninsured. They also have the greatest risk for those who has the greater risk of being uninsured. Those that are poor, those that are Hispanics, those with low education, those that did not finish high school, as we saw with Dr. Prochaska, or did not go into college, and the non-students. And again, as Texas is the leading state in the proportion of uninsured, it is also the leading state in the proportion of uninsured among young adults. So how do they use health care? That is before the ACA, okay? So let's see how they use. Less than half reported having a preventive care visit. And something that is very important, only 12% received any treatment for mental health or counseling in the past 12 months. And that's reported from the NHIS data, National Health Interview Survey. So uninsured young adults, they're more likely to say they did not go to look for care due to cost, they did not fill prescriptions due to cost, they don't have a usual source of care, or they reported more often not seeing a medical profession in the past 12 months. So if they're not looking at, so if they're not having prevention, if they're not having counseling, if they're not having treatment from their chronic conditions, and we saw these risky behaviors that they go and the high mortality, what do you think, where do you think is the healthcare utilization of young adults? Yes, ER. So they only lose for 75-year-olds or older in the use of ER. So we're seeing risky behaviors and low use of preventive services. That's the second key. So what happened with the ACA? There were policies that benefited young adults indirectly. For example, being mandatory to have coverage for yearly preventive visits, because prevention is important for young adults, indirectly that impacts them. Expansion of Medicaid, also important for young adults, especially those of low income, especially female-led households with children. Creation of insurance exchanges, these all indirectly impacted young adults, but the main policy that impacted young adults was the allowance of young adults to stay in their parents' insurance until the age of 26. And that's what really these researchers of the paper that we looked at, they measured. So they measured, did the coverage change or did the access to care also change among young adults? And since that policy took effect in 2010, they observed that right after that, it took coverage policy started in September of 2010. So they looked at the last quarter of 2010, and they observed that the proportion of those that reported insurance increased by 5%. So just right after the implementation of the policy. And by 2011, it increased by 8%. So before they observed 65% reported having any insurance during the year, to increase in 73% after the implementation of the policy. And what is interesting is that they observed that it increased across subgroups of the young adult population. Because remember, the disparities are also within the population. So it increased for both men and women across race and ethnicity groups, which is good for young adults. Healthcare access to care also increased in healthcare utilization. There was a decrease in young adults who delayed care due to cost, and there was an increase in the likelihood of usual source of care. So that paints a nice picture, that it did improve. But in summary, when we look at 2014 data and compare the healthcare access and healthcare utilization of young adults with their adolescent counterparts, they're still much lower. So the proportion of those with insurance after the ACA in 2014 was 69% among young adults and 89% among adolescents. And also, for example, dental visits, it did increase for young adult populations after many years from 2000 to 2012, from 52% to 61%, but it's still smaller than adolescents with 87%. And within this group, they still face socioeconomic disparities. And one group that I recently read about it in an Institute of Medicine report that still faces disparities are those with mental health disorders diagnosed during childhood that are eligible for Medicaid. Because when you are eligible for Medicaid as a child with mental health disorders, you are reassessed once you become 18, depending on your mental health disorder, to see if you're going to still be able to have Medicaid, still eligible or not. So for example, if a child has ADHD, is diagnosed with ADHD as a child, he or she is eligible for Medicaid. But once they're 18 years of age, they're reassessed, and near 1/3 of them lose eligibility. And if their mental health disorder is considered as other, such as anxiety or disruptive behavior disorders, and they're reassessed when they're 18, more than half lose eligibility to Medicaid. And remember what I told you in the beginning, what were the health issues of young adults? Mainly prevention and mental health diseases. So the fact that these individuals were able to receive care through Medicaid when they were children and they lose that eligibility at age 18, still with the same condition, the only thing that changed was age, is something that is important for us to understand the disparities that still remain in this population, even after the ACA. So in summary, I don't want to paint such a negative picture, but I want us to think about this population, just give them the time to think about them in policies and in research. And I would love to hear from you some ideas. How can we expand or maybe improve policy for this population? I have some ideas here, but I would like to hear from you. So how can we better observe these individuals, not only in research, but also in policy? Because as we saw, the ACA did improve care for them, but still not enough.
Thank you. Just a question, how many people are we talking about in terms of?
Population of the United States?
That is
Do
between
you have those numbers, Dr.
18 to
Prochaska?
24?
I
Yes.
don't know about that, but in Texas, between 18 and 24, there are about 2.7 million. Of those, 853,000 are uninsured, which is 32.1%.
So a lot of people.
And the story that Jacqueline has just told you is a common one that we see in the medical profession. I visited just last Wednesday with a young woman who has a genetic disorder that is craniofacial. She has had a lot of emotional and behavioral health problems because she's a subject to teasing and harassment, has not been able to complete school, and now she's facing loss of her Medicaid because this year she ages out of their system. So tragically, she has already had inpatient hospital admissions and all that, has a mother who is mentally retarded, and a grandmother who is incapable of managing where she lives. So there are kids like this that we see all the time in our healthcare offices. These are real cases. And we don't have a system in Texas or anywhere in the United States that really adequately addresses those kids that age out. The other issue that your pediatricians and adult doctors are addressing here at the Texas Medical Center, just think of this issue. We do a lot of heart surgery. Dr. Garson is with us tonight, and as a pediatric cardiologist, he knows all too well this. What happens to people who, when they were 6 weeks of age, received a heart surgery as they grow into adolescence and then adulthood. They are now presenting in their 40s in search of a doctor. They literally have no one who is comfortable taking care of them because they don't know the status of the surgery they had. And pick any kind of surgery that's done on children, and that's an ongoing problem. Where do they get the healthcare coverage for that disease? And who's prepared as a physician to take care of that condition? There are a lot of unanswered questions there. I don't mean to be posing more for you, but it is a lot more complicated than it looks.
Yes, I agree. And I think based on the numbers that you provided, indeed, is a substantial problem that needs to be taken seriously. Because that's growing, right? That's growing, correct? Yeah.
And policy initiatives really for young adults are not common. I don't see them. Do you, Dr. Linder or Dr. Garson? The people who can speak get a lot of attention, and that's those of us with white hair. AARP, it looks like young adults probably need an AARP, and so do kids on CHIP, because they're the last ones to receive policy attention. Yes, ma'am?
You did say that at 18 they were reassessed. Did you mean that they could keep going in some cases?
Yes, it depends on their eligibility criteria of what is considered disability or mental health disease under 18 of age and above.
So you have to be really bad off to continue it? Is that basically you're saying?
Yeah.
This person sounds like you're talking about.
Interestingly enough, we have made that exception among foster children. Foster children may stay on Medicaid until age 21, and some under special circumstances even higher, in order to access college and higher education. So we have made some exceptions in the state of Texas in those cases. Yes, ma'am.
Yeah, look, just to add on to your addition, so I was concerned about that as well. So if the person has the mental health disorder, like they have to get reassessed for it, even if they still have it, even mildly, they'll still be kicked off.
Yes. Unfortunately, yes. But as I said, I don't want to paint like this picture that we can't do anything about this, because we can. And one thing that I did, I went to Healthy People 2020. Sometimes I go there just to see, what are the goals towards young adult health. So there is a tab that you click, Adolescent and Young Adult Health, and they list this big list of problems, all of them that I talked to you about here as adolescent and young adult health. But as I showed you, young adults are far worse than adolescents. Then I clicked on the objectives and what are they doing about it. And unfortunately, all the objectives are only towards adolescents. Because think about the settings to intervene with young adults and to establish policies. Most of them are school-based, so the counselor observes the child and follows up. Most of them are systems that are only covered adolescents and children. So as Dr. Raimer said, they age out of the system. So they are systems that are sometimes just age-based. They don't consider other, like, for example, the mental health condition or other socioeconomic disparities that these young adults may have. So unfortunately, even though the problems are there, the policies are still not in place. There's just one policy that I found, and it's an example from Maryland. It's called Maryland's Transition Age Youth, and it protects young adults with disability and mental health disorders so they can, if they are receiving services as adolescents, they don't age out of the system. And they look at adult outcomes for these individuals. For example, finding a job, affordable housing, relationship with others. Like, they look at outcomes that are important for adults and help them in this transition. But this was the only one in the state of Maryland that I could find. And they do observe good outcomes. In their program, 70% of the young adults are employed versus the 46% of those that are not within their program. So there is one example. I just wanted to give a good light at the end, a good example of what people are doing. So basically using the systems that are already in place, the policies that are already in place, just supplementing them to be able to cover young adults, not just age them out of a system that is already in place just because they became 18 years of age. Oh, I see.
You talked about violence as a leading cause of death among young adults. How are we dealing with that as a health policy issue?
well, I'm not aware of any policies dealing specifically with young adult violence because, again, I have seen some in school-based interventions with violence for adolescents, but do any of you know of any policies for young adults and violence?
Well, I'll give you a real good example, and that is the right to carry on college campuses and in other buildings, Texas being very pro-gun state. I think there's really clear evidence that is policy gone the wrong direction. You know, our state government is not taking an aggressive stand on many of those things, and now some city governments are. San Antonio just upped the age for tobacco use and sales to 21 within the San Antonio city limits. So some local areas have more courage to address health policy issues affecting long-term health than our state government has been able to do.
I just also want to say that I've worked with youth who were incarcerated, so the young 18 to 25-year-olds who were addicted, and the 18 to 20-year-olds, it was very hard. There were very few resources to place them. So you've got mental health and substance use going back to the community and ending up on the streets because, so it sounds like there's a huge policy gap here for this.
Yes, hi.
Go ahead.
Oh,
Sorry. So you kind of posed the question of, are there any good ideas for policies for how we can help this population? And I'm kind of wondering if there's, I don't have any great ideas, just to lead with that, but I'm kind of wondering if there's been any research into whether incentivizing that population to get insurance coverage would work better than the Affordable Care Act, because the ACA, in addition to the stay in your parents' policy till you're 26, also had the individual mandate, which was more of it was a penalty. It was the stick instead of the carrot. Has there been any research into whether or not incentivizing that population to get coverage would work better?
I have not seen any research with that, but again, research is also lacking in the young adult population because we just group them with adults and see how adults are doing. But anyone?
okay.
Dr. Carson, we have a gentleman in a purple shirt that's had his hand up for quite a while.
Give it to the man with the purple shirt. Where'd he go?
He's right here.
Oh, good. Go.
Yes, I have a question about the evolution of the Medicaid program, particularly the different subtypes, whether it's STAR, STAR Plus, MMP, dual eligible people. And let me set the context because I'm a family physician at one of the local FQHCs, and last week I saw a 31-year-old lady who's 12 weeks pregnant, and the OB found a neck mass, okay? So Friday, she went to go get her ultrasound. She has a STAR Medicaid plan. And the ultrasound shows that it's a large mass with calcifications, which that is concerning for cancer. Well, apparently STAR does not allow her to go get a biopsy. So what are her options? She has to go apply for the gold card now. Thank God she's a Harris County resident, but other than that, she's gonna wait weeks, months, and that's really her only option right now. So, kind of alluding to last week when we talked about, how policy is made, the state, from my perspective, has basically left people like this on the table, which is, we do a pretty bare bones job of coverage and leave people at that. So if you could, sorry, it's a lot, but if you could talk about the evolution of these different plans and why we're the way they are right now.
That's a good example of when access is not really access, because you assume that you have coverage for something that you don't. And that's been the story of these plans. There are several ways to manage the Medicaid rolls. One is to decrease the benefits that those plans cover. The other is to make the enrollment so horrendous that you don't complete it. And the other is to shorten the time in which your Medicaid is, quote, good or usable. So you have to re-enroll frequently. There are a whole lot of tricks there designed for queuing and increasing client frustration to get through that. And I think it's safe to say that plans that are going to come out in the future are going to have more limitations than they do benefits. So doctors like yourself and the rest of the room will have to be very creative in looking for different options for their patients. So that's sort of a half an answer, but don't expect it to get better in the near future in Texas. It won't. Dr. Garson, I'm sorry to pass over you.
No, that's a great question.
There you are.
Couple of questions or a couple of comments and questions. We do a survey every year here for the past 3 years for the Health Policy Institute. Every year, it's either 98 or 99% of everybody in the country wants health insurance. They don't need incentives, they need money. And so this is not the thing that was so stupid, and it took me a while to figure it out, the thing that was so stupid about the mandate is people, 90-something% of people want health insurance. This age group, the 28 to 34-year-olds, want health insurance. They used to be the young invincibles. They're not anymore. They want health insurance. They just can't afford it. So I don't think they need stimuli. They either need cheaper health care or money. I have a sort of a question, and it's going to sound facetious, but it's not about the physician shortage. I was telling Stephen that I was sitting at a luncheon in Washington a couple of years ago, and we started talking about health profession shortage areas, and otherwise known as HPSAs, right? HPSA, and there's this definition that it's 1 in 3,500 people. That's the primary care HPSA definition. And so I, in typical style, said, where the hell did that come from? And the guy sitting right next to me said, I made it up. True statement, okay? So these numbers of 3,500, the whatever, ain't no basis for. So I guess my question to you is, how do we know in primary care that there's a shortage? How do we measure that? And let's not try HPSAs, because I'm not going to buy that one. So somewhere, either how long it takes to be seen, and I'm asking a question because I don't know. How do we do this? Is it miles? Is it distance? There are some people talk about that. Is it distance from a primary care doc? Maybe I don't care about that. Maybe it's distance to an emergency room. Maybe I do care about that if you're dying. There's as little data as there is with primary care, there's less with specialists. Nobody knows what the density for specialists should be. So how do we figure that out, Ben and Dr. Prochaska? What do we do? How do we know there's a shortage or not? Time to an appointment, distance, what?
Those are all great measures that we're potentially looking at. Another one that we're working on, particularly in tertiary care, so not tertiary care, tertiary prevention, looking at long-term care in rehab facilities right now at UTMB, is trying to identify what current practice looks like, what the market looks like in terms of where people are going upon discharge. So we're developing a clustering algorithm trying to identify what are service areas for long-term care facilities. And that might be a good approach as well to see what the demand is for primary care. A lot of the boundaries that we've seen are somewhat artificial. We see artificial boundaries in a lot of our health geography problems that we interact with. Zip codes, for example, is a common way to break up an area and look at it. Zip codes are designed and are very effective at ensuring efficient delivery of mail, but not necessarily how populations are broken up. Census tracts and other things also have limitations, particularly in more rural areas, for example. Some of the counties out in West Texas may only have 2 census tracts. One is the urban core around the county seat, and the other is everything else in the county. So it's a good question. And I'll end my statement with the classic researcher, further research is needed.
And I would just I'll come right back to you. I'm just saying that, you know, you look at Texas, I just happen to have this in my folder, Tim. 73% of the counties in Texas are designated health profession shortage areas, or HPSAs. And when was that designation made? Well, it actually made back in the 70s, and nothing has done to change it. You can literally go over to Angleton, Texas, and it depends on which side of the street your office is on as to whether you qualify as working in a HPSA or not. And that means whether you're eligible for loan repayment or whether you get discounts on certain things. So that's a valid concern. One thing that we have done is go to, with the AAMC, the American Association of Medical Colleges, they have taken a lead role in physician supply and demand. And they tie it not to HPSAs or anything, but number of physicians per 100,000 people. And what does that mean? Because of geography. Let me give you a good example of that geography. Visualize the southern border of Texas. There's not a wall there yet. Where do you think people get their health care for primary care? They go across the border and they get excellent primary care and dental care. And by the way, they also get to buy their pharmaceuticals very cheaply. I didn't learn that from books and all that. I learned it by asking our medical students who will open their mouth and say, these teeth came from Mexico. You know, I got my braces there, I got all my medications there and everything. The Valley is full of specialists because the people in Mexico who can afford it come across the border and get their specialty care. Now, if you look at the health outcomes there, they're not so bad, but if you look at primary care shortages, they're awful. But you know, the service area doesn't stop because of the Texas-Mexico border. You could go just a few miles over or a few blocks over and get care. Now, keep that in your mind and go to East Texas and go up the river between Texas and that other state, Louisiana. The health outcomes in the eastern part of Texas are atrocious. Tyler, Texas has the highest suicide rate of any place in the state of Texas because of an absolute lack of mental health services. STD rates are higher than anywhere in the state. So are deaths from preventable disease such as cardiac disease, pulmonary disease, diabetes, and all of those. Now, get in your car and drive across the Louisiana border, and what do you find? Access to health care? You won't even find a CVS until you get to central Louisiana. That's the way it is. So access to care is not about the number, it's about the distribution, and it's about the artificial areas that we draw. You can go into parts of Houston and there's an absolute shortage of physicians. You have no transportation to get into the medical center, even though it's the finest one in the world. You can't find your way down to Ben Taub Hospital because you don't have a way to get there. So I would put to you, it's all about distribution of physicians. It's not about the number. And we have to get, you're right, Dr. Carson, a much better way of dealing with that. Need to get that off my chest. Thank you, ma'am, for letting me. Go ahead.
Hi. So I have a question to piggyback off the discussion of the shortage of primary care physicians. What would be the role of, say, nurse practitioners in primary care, for example? Early November, I got the flu. I wanted to see my primary care physician, but she was booked. So I went to the Ready Clinic at the HEB by my house, and the nurse practitioner was ready to see me in 10 minutes. So I know that is more for short-term temporary care, but in long-term care, would nurse practitioners or, for example, physician assistants have a role in primary care in that aspect?
I have a very strange background in that I headed up the Texas Prison System's Health Department for over 8 years. We have a ratio of 1 physician and 2 advanced practice nurses or PAs that takes care of that chronic population. There are 150 people in that population, by the way. 30,000 of them have high blood pressure, 10,000 diabetes, another 30,000 have mental health disorders, and guess what? 28,000 are seropositive for hepatitis C. That's a lot of sickness in one place. And guess what the outcomes are in controlling blood pressure, your hemoglobin A1C for diabetes, and you name it, any other metric, including asthma. They're better than any managed care company in the entire United States. And we've published that in the New England Journal of Medicine. Because we have a standardized way of treating it, and we have really excellent healthcare providers that are both physicians and nurse practitioners. That is the future. PAs, physicians assistants, and nurse practitioners are going to be the future of our primary care health system. So all of these things that we talk about and come out from the AAMC like this, that says we're going to have somewhere between, 40 and 100,000 shortage of physicians. Those, I don't believe these numbers because I believe PAs and nurse practitioners will fill those roles and fill them very, very adequately in primary care. We are beginning at our medical school a whole new approach to the curriculum, in which we call just simply interprofessional education. We are building a new building in which all of our learners will be in one place. That will include doctors in the medical school training. They'll include nurses from the baccalaureate, master's, and doctoral programs. They'll include PAs, PTs, OTs, clinical laboratory science, all of those in one area. Because you know what? Healthcare providers don't know each other until they get into practice. And they carry with them a lot of baggage of who can do something better than the other. And if they learn in an environment and they learn to appreciate, we believe, each other's gifts in health profession, will work together much more efficiently. And guess what? We'll also be having social workers and epidemiologists and people with masters and doctorates in public health involved in those programs. So, you know, I think that's the future of healthcare, and we need to get all of these so many per 100,000 out of our mind and start creating medical homes that are based on this. Guess what? Your pharmacists ought to be a part of that. You know, a lot of people you can start thinking, community health workers ought to be a part of that. Tim has a really incredible program called Grand Aids, in which people are trained to offer healthcare advice. I mean, there's a lot of areas that we need to improve the delivery of healthcare, and we can do that by improving access and quality at the same time. So that was a great point. Thank you. You know how I feel about it. Yes, ma'am.
You segued into what I was going to comment on, was that really we need to reimagine primary care. And I'm a physical therapist, and I teach in the Doctor of Physical Therapy program at Texas Women's University. And you know, when I look at our military medicine model of primary care, physical therapists have been the musculoskeletal primary care providers, similar to the team you're describing with the NP and the PA, to do musculoskeletal care. And the outcomes are actually better, you know. And so now if we try to get that into the policy arena out of the military, that's an uphill battle right now for us. And you look at countries like the UK and Australia, they do the same thing. They do primary care very differently. And so I think that's one of the things, you know, from a policy perspective, we really need to think about. And then, you know, your point about hospitals that are not for profits and how much are they actually spending on community-based care, you know, and I have a PhD in health promotion and wellness, and one of my favorite quotes is from Lawrence Green, which is, let the people have a say and let the data lead the way. And I think that's what we're missing. Like, as healthcare providers, we get so siloed into what we're doing that we don't look around the doors around us, you know. And like, you know, I know big hospital system, not for profit, that sits in one of their hospitals sits in a not so great area, but there's not a whole lot of going on in the community just around the doors, And so that's the kind of stuff that we need to, if every one of those hospitals, 13, 15, looked around those doors, that's like probably 60% of Houston that, we could start engaging the community in. And so I think that's where policy really, we need to think about. And for young adults, to me, it's all about focusing on the young adults, because when you think about the population aging and then what's going to happen to that young adult population with absenteeism, presenteeism, and all these things, our economic power we lose as a nation, when that population is not productive. And so to me, that's important to me as a mother, that's important to me as a educator. As I get more gray, it's going to be important to me as a, in other aspects. And so that's a culture shift to think that young people are invincible and we don't need to focus on them now because we have all these other folks we need to focus on, but then we keep spending our money in tertiary care and not in that primary prevention mode. And so I think, that's the kind of thing that, would be wonderful of all of us, kind of be the champions of that here.
Comment on that.
Yeah, well, I'd like to speak to your comment about nonprofit hospitals and community engagement, and I absolutely agree. That's one of the things that we as hospitals need to do a better job in. And not just, a lot of hospitals are great when they do their community health needs assessments at asking community partners, even asking community members, what do you think the problems are? I think they do a really good job of that, doing surveys, doing key informant interviews, doing focus groups, but it ends there. And they need to keep the community members engaged in that process when they start identifying priorities, when they start coming up with programs or interventions or services to address those priorities. And I think part of this, it's not all hospitals' faults. They provide treatment, they diagnose, they do what they do well. And some hospitals do well at engaging communities. But what I have seen a bit of is they ask the community, what are your needs, what are your problems, what are your issues? And then a couple of people from the hospital get in a room and say, we think these are the problems and this is how we're going to address them. And they're really scared to pick priorities or interventions that they feel like they alone can't fix. And so this is why having the community partners involved. So an example of this, I was in a meeting in a different state, I was in Pennsylvania, with a group of hospitals and health systems that were identifying priorities for a multi-county area. And they said health behavior as one of their priorities. They wanted, and I said, that's great, but I think we have to recognize that the environment contributes where people live. We all know that, right? The zip code you live in can affect your life expectancy for up to 20 years. So we know where you live matters. We know the environment, your neighborhood, but they would not focus on the environment. They were comfortable with healthy behaviors. We can do something about that. But healthy environments, we're not going to go there. So I think by having communities engaged throughout the process, not just in asking about the problems, we will see a lot more happening outside the hospital walls.
I think we're out of time, and I'm getting this signal, which means either I'm crazy or it's time to wrap up. Okay? Thank you for being a wonderful audience.